orbital oculoplasty at Chaitanya Eye Hospital. Can an infant with epiphora be managed in a general ophthalmology clinic?
Here is the PPT. So good afternoon. Today's talk is about any infant with epiphora presenting to a general ophthalmologist. So can it be managed? About 90% can be managed by the general ophthalmologist because it usually resolves on its own. So when a child presents with tearing, the differential diagnosis will you should consider the associated symptoms. So if there is tearing with discharge, think of congenital nasolacrimal duct obstruction. If there is tearing without discharge, that means the obstruction is higher up. Look for an impatient puncta. If tearing is associated with photophobia, always rule out infantile glaucoma. And then tearing with pain. Look at the lid margin carefully. If there is blepharitis, think of staphylococcal keratitis, or look for a tracheitic lash, epiblepharon, congenital entropion of corneal foreign body, a corneal aberration, anything causing pain. And rarely, tearing with photophobia and torticollis can be associated with a posterior fossa tumor. The reason is not clear, but it's a known association. So the normal nasolacrimal excretory pathway, you all know, it starts from the superior and inferior puncta, drains into the canalicular system, then into the lacrimal sac, and finally into the nasolacrimal duct at the opening at the inferior meatus. So brief look at the embryology of the nasolacrimal system. So it starts as a surface ectodermal thickening at 32 days, that is 4 to 5 weeks, and it becomes well differentiated cord-like. It gets buried in the mesenchyme and canalizes at 60 days. So as this picture shows, canalization starts in the center and proceeds towards the ocular end and towards the nasal end. So any congenital lesion, you look for occlusion at the ocular end, that is the puncta, or at the nasal end, that is the inferior meatus. And as this picture shows, it's often associated with other mid-phase abnormalities. So this is a baby presenting with CNLD. You can see the purulent discharge at the medial canthus in the left eye, and there will be mattering and crusting around the eyelashes. Another particular feature is that it will be of chronic duration, and the child will be usually unbothered by her problems. If it is just tearing with watering and no discharge, then look for a impatient puncta. So how will you do screening for CNLD? We have to do a Roplus test or regurgitation pressure over the lacrimal sac. So the method is you first palpate the inferior orbital rim and then trace the orbital rim superiorly and medially till you reach the anterior lacrimal crest, and then apply pressure, sustained pressure with the index finger in a superior and medial direction for 45 seconds. If there is regurgitation, that is indicative of nasolacrimal duct obstruction. Also it indicates that the puncti and the canalicula are patent. I'm not getting the videos. Excuse me. I'm not getting the video. Thank you. So this is testing for Roplus in a baby. It becomes more time consuming, but again you palpate the medial end and you can see the pus coming at the medial end of the canthus. So what is the advantage of Roplus? It's a very useful, easy, non-invasive screening test with a 93% sensitivity and 99% specificity. So the next test that you can do is a fluorescent dye disappearance test. So if there is Roplus negative and still the patient complains of epiphora, then instill fluorescent in the conjunctival sac. Wait for 5 minutes. If at the end of 5 minutes, the fluorescent usually disappears from the conjunctival sac. But if it is retained, that means there is some obstruction in the lacrimal excretory pathway. And if it's Roplus negative, then look for obstruction in the canalicular stenosis or punctal stenosis, etc. Now, how will you manage? Most of it is conservative management. CNLDO is actually a variation in the normal development of the infant and not a pathological condition. So you can wait till normal canalization occurs. And conservative management includes lacrimal sac massage. If purulent discharge is present, you can apply topical antibiotics. Now, high pressure irrigation is a method in between conservative and invasive where you inject under high pressure and hope that the membrane at the inferior end of the nasolacrimal duct ruptures. Now, the invasive methods include syringing and probing, placing a silicone stent, and ultimately DCR. Now this is conservative management. You have to advise the patient how to apply the lacrimal massage properly. So you ask the patient mother to hold the baby across her lap, holding the head of the baby in one hand and the chin in the other hand, and then place the index finger between the globe and the nose. Apply firm pressure over the medial canthus. Your intention is to occlude the common canalicles and increase the hydrostatic pressure within the nasolacrimal sac, hoping that this pressure will open up the lower end of the nasolacrimal duct. So you apply pressure directed towards the opposite ear and then stroke the finger downwards towards the nose. It has to be done 10 times, morning, noon, evening and night. And this usually is continued till the baby is up to 12 months of age. Now this is a graph taken from a study that shows that spontaneous resolution occurs in 90% of babies in the first 3 months and continues to occur till the end of 1 year. After 12 months, the chance of spontaneous resolution usually plateaus and the need for an invasive procedure arises. Now, one of the rare situations where early probing is advised is an amniotocele. The baby is born with a collection of amniotic fluid or mucus fluid in the sac. This also means that both the common canalicles and the nasolacrimal duct are occluded and usually manifests at 2 weeks age. So the problem with this is the baby can develop periorbital cellulitis. So to avoid that, we do an early probing. Now, when do you refer to an oculoplasty? When you have advised conservative management for 1 year and still watering persists with discharge, then you refer to an oculoplastic clinic for primary probing, which can be done either as an office procedure. The advantage is there is no GA, but the chance of false passage is more. Or it can be done in an operation theatre under short GA. It can be done early as in an amniotocele or late as after 12 months. And the success of probing is inversely proportional to the age of the baby. So as the baby grows older and older, the chance of a successful probing becomes less. Actually, it's only 50% after 3 to 4 years. If you have an associated ENT department, you can do an endoscopy assisted nasal probing. Again, the chance of a false passage is less because endoscopically you can see the probe coming through the inferior meatus. Now, always the parents have to be advised that one probing will not be necessarily successful. Repeated probing may be needed with silicone stent. Then you can also advise DCR. But we wait for DCR till 3 to 7 years. We allow the nasal bone to grow and we don't want our surgery to affect the growth of the nasal bone. Thank you.
Thank you very much, Dr. Anju, for that wonderful talk.